Hello and welcome to this, the second in our series of short bite-sized booster sessions, education sessions that we're delivering as a part of Congenital Heart Awareness Week. And my name's Kay Nurse. No, it's not. It's Kay Walsh, and I'm the lead nurse for the Congenital Heart Disease Network here in the North East and North Cumbria region. This week is a celebration of everything congenital heart disease, but most importantly, it's about just raising the awareness of the population of young people, babies, young adults and adults out there in our region who are living with congenital heart disease in a variety of stages, severity, and sorry, I've got people joining, and severity. So it's really about just delivering something during the week to bring your mind back to congenital heart disease and raise awareness for this population. So as you know, congenital heart defects or any problem that a baby is born with to do with the structure of the heart. So present at birth, and it is an abnormal formation of that structure of the normal heart that we're familiar with. 25% of the babies that are born with congenital heart disease will require surgery or intervention to survive. And that means that 75% of the population of babies born with congenital heart disease can be out there living with this altered anatomy and physiology and just require sort of medical management, but can often walk a bit of a fine line of medical management, fall off the perch, kind of not doing so well at times, so require a huge amount of surveillance and monitoring and just integration of teams and pathways right across the region to keep these young people and babies safe when they're living with their congenital heart disease. But the 25% that do require surgery and intervention often need that quite quickly and quite critically within the first few days, first few weeks, first few months of life. And that can be anything from catheter interventions through to open heart surgeries. But with these population, what we do know is that surgery is not often a cure. So we describe some of our population of congenital heart disease patients of living on a palliative pathway. So this is a non-curable defect. They'll never have a normal anatomy and physiology. So you may or may not know, but congenital heart disease is the most common congenital defect that babies are born with. So 1%, that's 1 in 100 babies are born with congenital heart defect of some description. And there are many varieties and many combinations of defects. And when we talk about defect, we're thinking about altered normal, so an altered pathway of blood, an altered plumbing problem, an altered valve problems, a missing part, and an abnormal working part. So many, many combinations of these defects. But what we do know now from the latest data just published a few months ago, last month by NICO, who collect all of the data across the country, is that there are now an increasing number of adults living with congenital heart disease, and that's gone up significantly and is expected to grow exponentially in the next 5 to 10 years. And that's because we're just getting better at what we do as a collective group of professionals with the specialized skills and all of our interprofessional teams working across all of the non-specialized sites. We're just managing to give these babies and children better outcomes, better surgery, better intervention, better long-term management, and better knowledge of what we're dealing with now. So they are living into adulthood, which is fantastic news. So today's short session is just thinking about just going back to fetal circulation very briefly, again, very briefly, normal heart, and then just bringing us back to single ventricle circulation and what the impact of that means. And then I'll hand over to Deb Richardson, who's a specialist nurse at based at the Freeman Hospital. And she's going to just explain how we manage and monitor some of these most vulnerable congenital heart disease patients. So just thinking about fetal circulation, just an overview, of sort of brief recap, because what we need to establish from this slide is that there are two portals, ducts, pathways of blood flow that are absolutely critical in the first few days, first week of life in our single ventricle population. So the babies born with a single ventricle circulation will rely on these pathways of blood flow that are created during in utero, during fetal creation. So as the heart's forming, there are two essential pathways of blood that allow blood to bypass the lungs for oxygenation and move around the circulation. So ultimately what we're trying to do in fetal circulation is to move blood flow through the vessels and vasculature and through that evolving, growing heart. As the blood flow moves through in a normal direction and with normal volumes, it just expands and grows the vessels and the vasculature and allows for normal anatomy and physiology to develop. As part of that cycle, the oxygenated blood coming from the mum is essential because in utero we've got soggy, wet sponges as lungs, so they don't act as oxygenators. So the oxygen is all coming from mum, enters the heart into the right atrium, and then scoots across the first ductus or first pathway, which is called the foramen, and that's an essential pathway we'll come to later in the presentation. So this pathway of blood between the two collection chambers at the top of the heart, the foramen is a trapdoor that just allows the oxygenated blood coming from mum enter the right atrium, scoot across to the left side, ejected through the left ventricle, and then round the aorta to oxygenate the body, the rest of the evolving major organs in utero. The second ductus that we need to be aware of is this blue connection at the top half of the circulation, the ductus arteriosus, which connects the pulmonary circulation or blue circulation with the aorta, to the body circulation. And this ductus arteriosus becomes absolutely critical in congenital heart disease during the first few days of life, as many of these babies don't have a normal flow of blood moving around the body. So when they're separated from the oxygenated blood supply from mum, they become unable to move blood flow around their body in some way in the normal pathway. So the only way that some of these babies can either get oxygen or get blood flow around their body is to utilize these ducts that are only supposed to be there in fetal circulation. So normally they close off within the first 7 to 10 days of life, and that's normal. That's what happens to everybody. But in our congenital population, these become critical to survival. So what we know about normal cardiac function, blood enters the right side of the heart, so our blue side, into the collection chamber, the atrium, moves through to the ventricle, squeeze of the ventricle to the pulmonary circulation, so to the lungs, re-enters the heart in the left side into the collection chamber, empties into the pumping chamber, the left atrium, the left ventricle, and then ejects with force all the way around the big aorta, right through the body to the major organs and to ultimately your big toe. You can see from this diagram that there are a number of doors that are opening and closing with every ejection and filling and ejection of the heart. And you can also see that the blue side and the red side are deoxygenated and oxygenated side are working in harmony. So as each empty and fill, they are working synchronous. So there's a continuous reliance upon each side. So if one side starts to become ineffective, the other side will start to suffer as well. So they work together in a cycle, in this continuous cycle. It's important to appreciate the trapdoors and the direction of blood flow within the heart. Blood will only flow in one direction, and it is a forward direction. So the blood should always be moving in a forward flow throughout the heart. We've got 4 valves within the heart, and they allow blood to move from one collection chamber into the pumping chamber and ensure that blood is moving in a forward direction to the lungs or to the body. We have the pulmonary valve, which sits at the base of the pulmonary artery to stop blood coming back from that major outflow vessel. And we have the tricuspid valve, which sits between the two chambers on the right side. We have, again, the aortic valve, which sits at the base of the aorta, and the mitral valve on the left side. And again, it's just about the movement of blood in one direction, always in a forward flow. So our valves are an intricate part of the mechanisms of the blood flow around the normal heart. Another thing that we must lay the groundwork with when we're thinking about congenital heart disease is thinking about path of resistance and the way the blood moves around the body. The blood will always inevitably travel wherever it's easiest to do so, and we're designed in that way in our physiology from head to toe. The right side of our body is under the right side of our circulation is under a lower pressure than the left side, so our systemic circulation. So the left side of our heart has a much greater force to get the blood all the way around the body, and our right side has a relatively lesser force because it's trying to get it around the top half, the pulmonary circulation. But all of these pressures change on a constantly throughout the day as I'm talking, as I'm moving around, as I'm getting hotter and colder, as I'm standing up and sitting down. Our blood pressure is changing in order to meet the demands of the body as the resistances in our intricate network of pulmonary of vasculature changes around our body all of the time. So we're thinking about that principle. If we have altered anatomy within the heart, if there is a blockage, or if there is an absence of a valve or a vessel or a pumping chamber, the blood will find a way to go the easiest way it can. So getting back to the subject for today, single ventricle circulation. So what we do know is that single ventricle poses a complete complexity in the way that we manage these patients. But ultimately, at birth, one pump is not large enough or strong enough to work correctly. So we've already established that they work together. The right side is under less pressure than the left side, but they work synchronously. So the absence of a ventricle leads to major problems, which is why they're a complex congenital heart defect. I've grouped them here on this slide into left-sided problems and right-sided problems. So we're talking about the absence of a left pumping chamber or the absence of a right pumping chamber. And you can see there that there's lots of descriptions of how these congenital heart defects present. And it can be for a number of anomalies. So be that valves or pumping chambers or vessels not made right, but ultimately these are not developed whilst in utero. I couldn't possibly go over all of these today, and to be honest, you wouldn't want to in a lunchtime session. But what I have done is just chosen one left and one right to describe here today to set the scene. So thinking about the right-sided pump problem, I've chosen pulmonary atresia with an intact ventricular septum. So we know from our normal heart, which is pictured here at the bottom of this first slide, that the wall between the blue side and the red side is completely intact. And it's designed that way to separate the deoxygenated blood from the oxygenated blood. And neither the two should meet. So the normal physiology, the normal anatomy is that the blue side and the red side are separated. So that's what it means by intact ventricular septum. The septal wall is completely intact. So pulmonary atresia implies that it's to do with our pulmonary circulation. So we're looking for the defect in the pulmonary circuit. And atresia or atretic means absent. So there is a problem with the pulmonary circulation. So we're looking for that on this first diagram here. And what you can see from the base of this pulmonary trunk is that the valve that is normally there, the pulmonary valve, is completely absent. So it has not developed whilst in utero. This leads to, lost my cursor. This leads to an underdeveloped pulmonary trunk. So that T outflow tract that goes to the lungs is narrow and underdeveloped because it's not had a blood supply to make it grow and develop in utero. So we have no valve and no blood flow going through that trunk. And you can also see from this first diagram that the right ventricle does not look normal, and it doesn't look the same as the normal heart. So it is thickened because it's been desperately trying to get the blood to the lungs via a very narrow outflow tract, so an outflow pipe. So what we know from this picture here is that there will be very little or no blood flow going to our lungs, which in turn means that we have a cyanotic patient with insufficient oxygenation occurring. So this is incompatible with life. You cannot survive without some sort of intervention. So we can see the blood from the right atrium enters the heart, comes into the right ventricle. The right ventricle cannot eject its blood to the pulmonary circulation. So the blood moves backwards, which we know shouldn't happen, but it moves backwards back into the right atrium and moves across the formano ovale. So you remember that trapdoor at the top of the heart in between the two atrium. The blood flow moves back and crosses over from the right side to the left side in order to find its way out of the heart. So that is the easiest way for the blood flow to go. So path of least resistance. So it comes back up the way, goes across into the left side, and then ejects around the body. So we've got blue blood now moving into our left side and going around the body. The only way that this patient has any blood flow or some blood flow going to the lungs is via the ductus arteriosus, which you can see connecting the aorta to the small pulmonary circuit at the top there. So blood that leaves the left atrium, left ventricle, going through the aorta, some of it will steal across the ductus arteriosus and manage to make its way to the lungs. So there will be some blood going to the lungs. So we know that this patient has insufficient blood supply going to the pulmonary circulation, going for oxygenation. The picture on the right-hand side is describing some of what Deb's going to go over in her slides, but some of what we can do. So we need to establish, I say we, the surgical team, not me personally, but the surgical team need to establish a sufficient blood supply getting to the lungs, and they do that by adding in a conduit, which is a stent or a false piece of material that they attach to the ventricle, they attach to the pulmonary artery, and they make it a bit bigger, and then they can now get the blood flow from the right ventricle through this new piece of tubing, which acts as a pulmonary artery. And then you can just about see on this diagram in the T-junction that they've put some coils in. So they put springs inside which open up those pulmonary vessels as well. So we've now got blood flow which can get from the right ventricle through the pulmonary artery and then make its way to the lungs because we've dilated them up a little bit as well. So these babies rely upon this new additional piece of tubing that's been put in surgically in order to get some pulmonary circulation. So going to the left-sided problem now, we've got hyperplastic left heart syndrome. And again, this is a whole huge topic on its own, but we want to just give you a taster. So hyperplastic left heart is the absence of the left pumping chamber. And in the absence of the left pumping chamber being formed, it therefore hasn't grown the aorta because there's been insufficient blood supply going through the aorta. So the valve hasn't formed, the aorta itself hasn't become a big, fat, juicy aorta which delivers blood to the body. So therefore, we're all underformed on the left side. So we're thinking about the systemic circulation now. So these babies, again, are critically reliant upon their ductus when they are born to enable some blood flow to get around the body so that it's a completely mixed circulation. therefore they are cyanotic population, so they're a blue presentation baby, and this is also a critical circulation. So without their fetal ducts remaining open, these babies are also incompatible with life and require intervention very early on. So within the first few weeks of life, what the surgical team will do is intervene by trying to create an aorta. So they'll put some patch reconstruction onto the aorta and create a new aorta from the pulmonary artery. So the pulmonary artery then becomes the new aorta. But you can see now that there is no connection between between the right ventricle and the lungs. It's been taken away in order to create an aorta. So what they do in that second picture along again is put this false bit of tubing to enable some pulmonary blood flow. So the pulmonary blood flow is reliant upon this new conduit, so this false bit of tubing, so a new vessel that's been put in. Moving on to the third picture, the second stage of surgery happens around 4 months to 6 months of life, and the babies normally by this point have outgrown this bit of tubing, and we need to give them a little bit more of a permanent solution to that problem. By this point, the vessels have grown a little bit because the child's grown. So now what the surgical team can do is take away the false bit of tubing, and they connect the top half of the body, so the SVC from our first diagram, then is connected to the pulmonary circulation. So all of the blood coming back from the top half of the body goes straight to the lungs. So we've now got a bit more of a sustained circulation, and this will carry them through to around preschool age, so about 3-4 years old in best case scenario. So before they get to school, they'll come back into the surgical centre and they'll have their final stage, their palliative surgery. And what they do in this stage is connect the bottom half of the body, the blue blood coming back from the body, to the pulmonary circulation. So we've now got the top half of the blue blood and the bottom half of the blue blood draining straight into the lungs. And now for the first time since birth, the baby or the child by this point has two separate circulations. So after this surgery, they will ultimately be pink for the first time. So all of the blood coming back to the heart is going straight to the lungs via the IVC and the SVC, and all of the blood returning to the heart after oxygenation by the pulmonary arteries comes into the pumping chamber and then goes round the heart, around the rest of the body. So like I said, for the first time, they will have two separate circulations and they will be pink. I'm going to hand over at this time to my colleague Deb, who's going to talk you through the intricate monitoring of these patients.
Hi, I'm Deb Richardson. I'm one of the children's cardiac nurse specialists from the Freeman. I'm just going to try and upload my slideshow. Just give me 1 minute.
That's okay.
PowerPoint. Okay. Can everyone see that? Can we all see that?
It's thinking about it. I can't see anything yet. Oh, you can see it?
Yes.
Yeah. Hi, so my name's Deb Richardson. I'm one of the children's cardiac nurses at the Freeman Hospital, and I'm going to talk about the babies that we look after and keep them safe because they have these very small shunts or little tubes in them between stages 1 and 2 of their palliative surgery. So this is hyperplastic left heart, and this is an echo of it. I don't know whether it's moving, it's not on my screen. And this is one of the most serious conditions that a child can be born with. We meet families antenatally and counsel them that they can have three choices, and the choices are either palliative care, which is comfort care when the baby's born, termination, or we offer 3-stage palliative surgery. We tell them at this point there is 70 to 80% chance of these babies making it to school. So in the long run, 20 to 30% of these children won't reach school. We tell them it is a life of uncertainty, and the first operation usually happens within the first week of life, which is very high risk. Occasionally, there is a particular lethal variant of hyperplastic left heart with those who have a restrictive atrial septum, and in this situation, fewer than half will survive. So that's a 50% chance of survival. We occasionally, when we counsel these families well, we occasionally see these babies, but these babies need extra special care when they are born from the team. These babies need an immediate procedure as soon as they're born. So I don't know whether you can see on the screen there, you've got a little window here. So the baby will be born through this window here, and as soon as the baby's born, will be passed through into the cardiac catheter lab here. When they're in the catheter lab, the chest will be opened immediately. A stent will be placed to decompress the left atrium. This procedure is now being used in most Northern American hospitals as a result of publication from our hospital, but most centres in this country don't do this, and they will offer termination or palliative care for these babies. So the usual course for hyperplastic left heart baby is to have high-risk surgery within the first weeks of life, and you can see how critically unwell this baby is in intensive care. The chest is often left open. It's our point as the cardiac children's nurses to reconnect with the families and to help them adjust and cope seeing their baby like this. And it's also the start of building a relationship of support and care. This is a very high risk period, and sadly some of the babies don't survive. However, after groundbreaking interventions, high-risk surgery, excellent care from the team on PICU, and later on the ward, many of these babies are ready for home. And many of the problems only begin when they are discharged home, as it is well documented that during the interstage period, which is between stages 1 and 2 of surgery, some of these babies will die at home. You are seeing my next slides, aren't you? I'm just checking. Yeah. Okay. So this is data from Wisconsin, who were as equally frustrated as us about the deaths at home, and they compiled a study to see if a program of home monitoring improved mortality. So this, I don't know whether you can see on the screen, is a Kaplan-Meier curve, which shows the death rate of children who were not monitored. So they showed that by introducing a home monitoring program, which involved sending babies home with weighing scale, saturation monitors, a red flagging system, and a diary for parents to fill out with extensive training, the red flagging showed early deterioration. They changed their mortality from 15.8% to 0%. So which conditions are included in our package? So we set up our own package of care, which I'll go on to later, but the conditions that we include are all our single ventricle children, which is our hyperplastic left heart, pulmonary atresia with tricuspid atresia with hyperplastic right heart, our unbalanced CAVSDs, and we get a lot of children with a lot of variations in this, and we call these our really complex babies. And the biventricular children, our pulmonary atresia VSDs. And whether, I know Kay showed you some diagrams before, but this is just the hyperplastic left heart. And after the first stage, which is the Norwood stage, they can either have a BT shunt, which Kay showed you in her diagram, or they can have a Sano shunt, which is a tube that goes from the right ventricle straight into the lungs. And this is again why these babies are unstable at home, because if either of these become blocked at any time, then they will not get their pulmonary blood flow and they will collapse. The other children that we have included in this, we originally started this program just for hyperplastic left hearts. We covered all our children who have ductal stents or the BT shunts, and you can see the BT shunt then, and you can see this is where the ductal stent would be, where Kay showed you earlier in the patent duct arteriosus. So we've taken the best components from Wisconsin data and other similar warning tools and put them together to make our own unique package. This is supported by our charity Chuff, who buy the weighing scales and saturation monitors for these families. We spend time on the ward teaching the families about their heart condition and the fragility of their baby's circulation and how quickly they can become sick. We ask parents to fill in a diary prior to leaving so we know they can identify the red flags. And the red flags, I don't know whether it's clear at the bottom, these are questioning what the child's normal oxygen saturations, any weight loss or static weight, what their fluid intake is and what their breathing's like. They are also taught BLS on the ward before they leave to enable them to cope with an emergency when they're home. So we are enabling parents to become the expert on their child's care, and we will always have a discharge planning meeting for these children. Before they can be discharged on the ward, we've got a checklist because they've got to fulfill this checklist before they can go home. And it's things that they've had the training. They can fill the diary out because we have had parents in the past where they've just been unable to fill out the diary, or they've been unable to recognise signs of when their child is sick. So it's like a competency that they have to do. Towards the end of that checklist is things that we have to do. We have to let the local hospital know. We have to send the information on. We have to make sure the health visitors, the community nurses, and everyone's informed. We also send them home with an emergency care plan, so all of these children get one, and this is a document which is just for document sharing, mainly for ambulance crews and for other hospitals. And this can be invaluable when parents call 999 or being admitted to hospital. It's got up there what their normal oxygen saturations are. It's also got on here how much fluid the child should have within that day. And this is because in the past we've had a child whose shunt become blocked because they were dehydrated. So we've got to make sure that their fluids they're well hydrated. Along with that, in collaboration with Great Ormond Street, Birmingham and Southampton, we produced an easy read traffic light system for all our vulnerable babies. So green is generally they're good to go. They are normal signs. And we tell parents to ring us when they hit amber. So it's just things like they're quieter than usual, they're slightly irritable, they're sleeping a bit more than usual. This is why it's paramount that parents spend as much time on the ward getting to know their baby before they take them home, so they know what is normal for their baby. Obviously, if it hits red, that's when we say you need to call an ambulance. We always instill in parents that babies will get to this stage, the amber stage, before they hit red. So we always try and get them to call us or call the ward prior to them hitting a red. We've also recently introduced this documentation, so all parents go home with a file, and in the file it's got the emergency healthcare plan, the chat tool, the diaries, and it's also got this information here, and this is specifically for other health professionals, GPs, or when they turn up in a hospital or an ambulance. It explains what the whole monitoring programme is, which conditions, why they are needed, and what the red flags are. It's just to go alongside the emergency healthcare plan in detailing what their condition is. So how do we monitor this? So we have a vulnerable babies telephone clinic, which is protected time every Wednesday afternoon. Parents know about this and they know that they have to be in, because if they can't be in for this telephone clinic, then they will have to be seen in the clinic. So we have a number of questions that we ask parents. We ask what the baby's colour's like, what their breathing's like, are they tolerating their feeds, what their weight is, what their SATs are, what their heart rate is. And if they have any, and the big question is, are they worried about anything? So all this info is recorded on a spreadsheet, so we can clearly see any differences in weights and SATs, and it's also recorded now in our e-record, in our internal note making on the hospital system. A lot of the time, we may need to speak to a doctor, or we may need to do a follow-up call. So if they haven't gained weight, we can adjust the feeds, give them a call in 2 days' time. That's why we have it on a Wednesday, so we can always follow up with something, or we send them to hospital to be checked out, or we get them into clinic to be seen. So the benefits of a home monitoring programme is that parents become empowered to become the expert within this interstage period. We can admit early with red flagging and the chat tool, and this is if anyone's got any beds over this time, but usually if one of our vulnerable babies is sick at home, we'll try and get them in here. If not, if we have no beds, then it is to the local hospital, or if they're really sick, then they need to go to a local hospital to be assessed first. Our data and all our notes is accessible to the wards on a weekend, and we've got our database to do an audit one day when we will have time. Ultimately, though, the family at home, because we have had a lot of children who stay in hospital interstage. And currently we've been doing this programme for the last 6 years, and our mortality, interstage mortality, is at 0% as well. So it's a growing and developing service. We have this telephone clinic. We've enlisted that to include other vulnerable patients, which is pre-surgical patients, patients in heart failure, our palliative care patients as well. And just to, on a nicer note, this is one of our vulnerable babies who she is between stages 2 and 3, and she is one of the 70 to 80% that do make it to school. And she is currently enjoying life and loving school. And I've just realised this little girl has just come into her had come in to have a 3rd stage operation, palliative surgery. It didn't work, and she had to revert back to her 2nd surgery, and she had a long period of time in hospital. Okay, and that's it. Is there any questions? Sorry, I feel like I've had to get through there quickly.
You did. Thank you very much. And thank you very much for speeding through them. There is an awful lot of information to take in. Like I say, we tried to cover this session. This session was asked for by a lot of my regional colleagues, so it's an awful lot to fill in half an hour, but hopefully we've given you a taste and signposted towards some more learning. Thank you very much to Deb for joining me today and all that valuable information. I really appreciate it. Thank you. So hopefully we've managed to cover sort of an overview of this very, very complex circulation, and give you an insight as to how we're trying to support these babies and young people to try and live as normal a life as possible with the help and support of all of the teams across the region. So thank you so much for listening and for getting involved. If you need any further information or want any more resources or signposting, please take a look at the network website. It's there for you. If you have any comments, please give me a shout and I will be happy to hear from you. So thank you everybody for today, and I will let you all go. Has anybody got any questions? Nothing? No?
No, thanks, girls.
No.
Very interesting.
Thank you very much. In that case, I will say goodbye and enjoy the rest of your day. Thank you.